Irwin. You're the only one on so far.
Hey, good evening. How are you?
Pretty good. How are you doing?
I'm doing well. I just finished my clinical last week, so feel like I got a lot more time to study now. So I've really
Okay.
only just been listening.
You really need to go over. It's probably a good idea to actually print out the assignments for each week
Mm-hmm.
and use that as a checkoff list.
Okay.
Do you have to do them all? No. But do you need to think about all of them? Yes.
Okay.
So if you have questions, go look them up.
Okay. That
The
sounds
information's definitely there in the form.
okay. All right. Yeah, I've got a lot of time in the day. I've been reading some of the Score Builders book. I know you didn't recommend the Score Builders, and I
It
compared your information.
actually, it's sort of a good start. It just doesn't go far enough.
Okay.
It doesn't get in the complexity or sometimes the detail that you
Okay.
need on an exam. It is definitely better than the therapy ed materials,
Okay.
which I find being fairly old.
The O'Sullivan one.
The O'Sullivan based.
Okay, I got you. Okay.
O'Sullivan by itself is pretty ancient,
Hmm.
and the latest one I saw, they didn't put, they referenced everything, but they didn't put the dates on any of the references.
Okay.
That's because some of them probably date back to the 70s. Now, some old stuff is still true, but some is not.
Okay. All right. I'll definitely get all the assignments and there's only 3 weeks left, so
Yeah,
I'll go through them as good as I can.
yeah, we're about done with the webinars. All I see is one to give next week. I think I've blown through the whole list. Maybe we'll see. Did I do gait, orthotics, and prosthetics with you guys?
Yeah, I missed the gate last night. I didn't realize you were doing one every night this week.
Yeah. Well, I have two classes going, and one's Monday, Wednesday, Friday. The other one is Tuesday, Thursday, Saturday morning.
Hmm.
So, yeah, I sort of blow through them.
Okay. Okay.
Well, I'm trying to figure out what to do next week because one class drops off on Monday.
Hmm. That'd be us, won't it? Yeah, that'll be us.
Yeah, you're the ones that started on the 7th.
Right. Mm-hmm.
Yeah, you guys drop off then.
Okay.
Hello, Phil. Thanks for joining.
How you doing, Tim?
Waiting for others. I got 11 registered for it, and I got 2 of you on. So
Was
I think there will be a few more.
was the gate class that you were speaking of the same gate class that we had before?
Yes,
Okay, just double checking.
just another rendition of it.
Gotcha. How you feeling?
Actually, pretty decent today.
Good.
Day
Good to
by
hear.
day, I'm feeling better and better. So
Good to hear.
I still have shingles that are bugging me like mad, but
Hmm.
I spend the whole morning at the doctor tomorrow, so we'll try to figure that one out.
Can I ask you a question while I got you real quick?
Yes, please.
I'm trying to narrow my focus on for studying for the PT exam on standardized outcome measures. Have you seen a trend in Berg Balance Scale or Tonetti or others over the?
To be honest with you, what they use on the exam is not the scoring in those things, any of the scales, except for Glasgow that had scoring in, and Abgar they've had scoring in.
Okay.
Most of the time they don't have scoring as being part of it, but they have the components
Okay.
because there's several different scales out there. All of them tend to reuse similar components to it.
Okay.
And they're more after the components because that's what you're actually testing.
There's just so many of them. I'm trying to measure or remember all the components for each. And
Really what's important are the ones that are the same, that you see in multiple scales.
okay, like balance and
Hmm.
okay, gotcha.
And balance itself is a mix of 3 things. It's vestibular, but
Mhm.
actually the largest component is proprioceptive.
Okay.
So we
Indeed.
feel where we are. Then there's vestibular, and then there's
Vision.
vision. And vision really is a compensation tool because blind people walk just fine. Their balance is great.
Okay.
The problem is they walk into things.
Yeah. Do you,
But
like,
their balance, for that matter, is relatively good.
speaking of vestibular, do you see the cat sib tests on the exam, or do you ever see like, Epley maneuver for like BPPV, or is that?
They have pre-tested it,
Yeah.
and it showed up like one time and then went away.
Ah, okay.
That's something when you're starting to get into more an advanced practice than you are an entry-level practice.
Okay.
You may have pre-test questions there.
Yeah, the nystagmus direction and to which canal, that confuses me.
Nystagmus is lateral, so it's rotational movement, and it's the lateral canals.
Okay.
That one you see quite often. It's more not caused by the canal often, it's more caused by problems like at the fourth ventricle of the adducens nucleus being affected. And the adducens nucleus is right next to the vestibular nucleus, and there's a lot of tracks in between. The other one is clear up in the oculomotor area in the trochlear, and that causes saccades, which is up and down.
Hmm.
You have somebody look up and you'll see a flick, or you have them look down, you'll see a flick. That's rare to see.
Okay.
If you've injured that part of your brain, you've also probably injured your thalamus, and you're probably not alive anymore.
Okay.
So we don't see a lot of that one.
Yeah.
The midbrain really, for a patient to be viable, they usually don't have a lot of midbrain problems.
Okay. Now, what about Meniere's? What separates that from other forms of vertigo?
Meniere's is an inner ear problem,
Okay.
and you can put some cold water in their ear and it'll trigger the Meniere's.
Okay.
That's one test for it.
Okay.
And you gotta sort of separate that out. If you got positive Meniere's, they really need to see an ENT, ear, nose, and throat specialist.
Okay.
And you see Meniere's, maybe a history of a swimmer's ear or something like that, likely to give you Meniere's. And they throw little clues like that in the exam questions too. There's usually multiple things that are causing you to start looking a certain direction. And that's what they're looking for.
What are the two tests again that like the tuning fork by the Maslow's process, and I'm trying to remember, it's like rhyme or Symes test, or I saw that on the exam before.
I don't know.
Weinstein and all right.
Oh, Weinstein filaments?
Yeah.
That's like a toothbrush with one bristle.
Oh no, that's for like the
And the bristles have different feelings, so it's a fine proprioception test.
Okay.
It's a good screen for patients with diabetes to see if they're putting too much weight on their feet and not feeling it.
Yeah.
And it's used primarily for that.
I
Yes?
think you may be talking about the I think it's RINNE test. That's
Yeah.
one of them. I think that's it.
Yeah, I think you're right.
Okay. But I do know it's for what you're talking about though.
Thank you.
You're welcome.
Okay. Tonight we're talking about research and evidence-based practice. There's probably as many questions over evidence-based practice as really how you use the research. And there's not a lot of difference between authors on that. And there aren't too many authors that even address it, but the ones that do, they're fairly consistent. The problem with the stats and the research methods is different statisticians use different terminology for everything, which makes it really hard to understand. If you got one textbook that's saying one thing and you get another textbook that's using totally different terminology, you may not realize that they're actually talking about the same thing, which makes it very hard to write exam questions, because you want to have an exam question that goes across at least most of the textbooks that are used in PT school. And there you're going to be probably lacking. It is important because that's how we obtain the information, how you see what the evidence is. But you got to make sure it applies to your situation too. Entry-level therapists are primarily a consumer of research. You're not really conducting it, but you're definitely should be consuming it to improve your practice throughout the years you're practicing. It should be part of your daily practice of reviewing it. Maybe you have a question over a patient you saw that day. Go back and look that up that night and try to do a little bit of research on it. There's a lot of stuff on the internet available to you. It's not all created equal. There's a lot of ways to look it up. Most of us look up with electronic searches nowadays. Reading research is something that a therapist really should do almost on a daily basis. Meaningful and relevant research to you may result in your modification of how you're practicing, the treatments you're doing, maybe what tests you'd be doing to determine problems within patients or monitor patients' improvement. All those come out of the research, and you should be constantly improving yourself. It's not just taking a conference once a year. When you're taking the test, the math should work out easily. If you feel like you need a calculator, you're probably setting up the equation wrong. So go back and see how you're doing it. But you are expected to know the meaning and uses of certain commonly used medical statistics. Really what you're doing, really what they're trying to see is how can you interpret a research study to fit your practice? You need to evaluate them. And really one thing you need to look at, and I'll go through this, I'll hit this pretty hard, is the method they use to do this study. If you're reading a study about ultrasound, they used an ultrasound generator that generated 30 watts per centimeter squared. In the clinic, you can get up to 2 watts at most. It's not relevant at all because you cannot repeat that in the clinic. Some studies are done that way to get a certain outcome, and that particular study was definitely done so that they got an outcome that showed a lot of tissue damage due to the ultrasound. That would not be a relevant study. I have seen it requoted in quite a few modality books, though. Research is really a process. You start with a question or a problem. Usually this would be in the introduction. There should be a very clear articulation of the goal of the research. Again, probably more in the introduction. Then there's a plan and how they proceed, what type of equipment they used, how did they actually do it to get the results they got. That's what you really almost have to focus on more than anything else, because that tells you whether or not you can use it in your clinic or not. If it's parameters that you can't possibly repeat in the clinic, you can't use it. APTA, physical therapy, when they edit things or even accept a research study to publish, they want to make sure it can somewhat be repeated in the clinic, that it actually makes sense. Research often divides one problem into several manageable and testable subproblems. They may not be able to prove the big thing, but they can prove all these other things. And if you prove all of them, then that sort of proves the big one that you're really after. Research is guided by specific problems or questions, such as hypothesis. A hypothesis is a guess of what happens. Medical statistics, or statistics in general, are sort of a reverse way of thinking, because when you're actually doing the math behind it based on the data you accumulated, you're really trying to prove the research hypothesis is wrong. And if you can't prove it's wrong, then you have to accept it. So it's got that reverse way of thinking about it. And that sort of makes research hard to understand. Research is based on previous research. And if you read a whole study, they may actually give you a pretty good listing of what it's based on. Maybe one of the theories that it's based on has found to be untrue or something. That would almost invalidate the whole study. So you got to look at what assumptions they're making. And the assumptions really have to be true for the study to be true for you. They may be true for somebody else, but maybe not for you. Maybe it's about a different population than you're dealing with. Research requires a collection and interpretation of data in an attempt to resolve the problem. That data is analyzed by statistics, usually presented within the study there, and the data actually doesn't prove the conclusions necessarily, but it definitely supports them. Research, being a process, is research spurs research. So there's sort of a cyclical pattern to it. Whenever you look at your sample population, you may find a couple patients that just simply don't fit. They're outliers. Well, there's something different about those two patients. So the next research is finding out what in the heck is different about them. How can I look and accommodate that? Why did those two have very different reactions to whatever I did to them? What other diseases might they have or something like that? But you try to figure out why didn't they fit in to what they should have fit into. When you're reading, you really got to know what the study's trying to prove. This is sort of like what research study to read. If it's something you want to know, then go ahead and continue reading it. Usually the introduction will get you there. Population is important. Something on 3-year-olds may not be too appropriate for you treating 90-year-olds. May or may not be, but you need to think about that. Studies are often based on other work. As I said, finding the outliers from a previous study and trying to go in and figure out what's going on there. You may need to read some of the other studies also that's based on. Do the results support the conclusions? The results are the statistics and the mathematical manipulations, but do they really support what the conclusions are trying to say? Now, in a jury journal like physical therapy, physiotherapy out of Canada, they probably won't publish anything where the results do not support at least the initial conclusion. They may not support the secondary ones, but the initial one, it has to support. What results? Well, how large was, could this affect your patients? How large was the effect? In other words, how much does it make a difference to you? I remember reading one on the temperature of ultrasound gels, and warming up the ultrasound gel decreased the ultrasound transmission by just an infinitesimal amount, but it did consistently do that. So that was significant. The amount of difference was so small that it really made no sense to change what you're doing. And sometimes putting really cold gel on somebody when you're trying to get them to relax may not be the best idea in the world. On the other hand, I don't like ultrasound gel warmers either, because then the ultrasound gel is running all over the place and you lose the consistency that you need. You have to decide the validity to you as a therapist and the populations you're treating. Study may be valid to some therapists and not valid to you. And validity is a judgment you have to make as you're reading or after you've read it. The internal validity usually has to be proven from the results in anything that gets by a jury journal. They won't publish it other than that. Now, Advanced Magazine may publish it, some other websites may publish it, but probably not something that's juried. Who is actually doing the research? Most research is done by primary purveyors because they've got the money to do it. They're trying to develop something and trying to test if it works. They're also promoting the use of a test, a piece of equipment, or treatment. So there's a little bit of a sales job going on here too. They should disclose who's paying for it. If a drug company is paying for a study done on their medication, the researchers really want to show that the drug works. They really don't want to necessarily show the side effects of the drug so much. That was a problem with Merck and the Vioxx issue 15 years ago or something like that, where Merck got sued royally over that because they suppressed all the information that they had about the side effects of Vioxx. They knew it, but they didn't publish anything. And they paid people not to publish. So primary purveyors you always have to be a little skeptical of, because they're trying to sell something and it is a sales job to some extent. Secondary purveyor is more of a scholar who examines tests or treatments. National Institute of Health was actually developed to actually do second purveyor studies. And they came up with one where they showed that one of the best drugs to control blood pressure was diuretics, because they really had the most easily catchable and undoable type side effects to them compared to calcium channel blockers and some of the other medications to control high blood pressure. So they came out with that was best. Well, diuretics are really cheap. Drug companies don't make any money on them, or very little money on them. They'll say they don't make any, but they make a little bit. They wanted to sell their calcium channel blockers instead. So the pharmaceutical industry really lobbied against NIH to a great extent, where their funding has almost been cut back every year since that study hit. And they're doing a lot of primary purveyor type studies now, where a company will pay NIH to research this for them. It still is a little bit more independent, but you still want to please the person that's paying you. And a tertiary provider is somebody that instructs you, or they prepare instructional materials. So it's more of a teacher type thing. It is a little bit of their opinion, like everything, but which may be okay, may be faulty, but they're going to talk about information gained from either the primary or secondary purveyors. We see a lot of the primary. Now, there's some secondary purveyor research like dissertations, things like that. That type of research probably is more of a secondary purveyor. Not always, but often it is. Some good sources of evidence. The Cochrane libraries, which gives you systematic reviews. That's something that if you have an APTA membership, you can address. Again, Hooked on Evidence from APTA is another one you could look at to address. Now, Hooked on Evidence isn't nearly as complete, but does have stuff from the APTA journals, including the different sectional journals, and from other sources as well. So maybe a good one to look at. Medline, if you're working for a hospital or a fairly large organization, they may have a Medline subscription. There's Medline Plus, which is more of a patient education-oriented website, which is free and that's open. But Medline is not unless you have a subscription to it. And the subscription is relatively expensive. You can still look for articles there, but to get a study, it's probably going to be $30 here, $30 there to get a study. PubMed is the Library of Congress. They have a lot of studies available too. Pretty much anything that's published on Medline would probably be in PubMed as well. Again, you often have to pay to actually see the whole study. You can see an abstract, but you can't see the whole thing. And the abstract doesn't give you the methodology often to the detail that you need to be able to see if you could use it in your clinic. Synthol is a nursing one. WebMD is not bad. It's actually owned by AMA, American Medical Association. So it's actually fairly decent to look at. It does have patient education level to it, but then there's a deeper level as well for medical providers. Medscape is for medical providers, primarily physicians, but it gives us a lot of good detail. There's also continuing education credits that you can get through Medscape as well. Healthline is sort of similar to WebMD, but it's run by the osteopaths and covers sort of the same things. It's more of a patient education level. National Institute of Health and the Center for Disease Control both have websites. Those are federal ones. They're really well researched, good information there. Other sources are APTA publications, including the sectional publications, like neurology and sports medicine has their own journal. Orthopedics and Sports Med has their own journal. Cardiopulmonary does, geriatrics does, pediatrics does. So those are sources you could look at. Most of the journals that are over a year old are in the public domain. APTA will let you on those for free. You don't need to belong to APTA. And you can even do an electronic search through those. So You don't necessarily have to belong to APTA. The membership gets you into the newest stuff that's being published. By the time information is derived from a research question and actually makes its way onto the exam, we're talking maybe 3 to 5 years. So it takes about a year to develop an exam question. So you don't have the absolute latest on the exam. So don't worry about October's physiotherapy. You may need to think about more last year's October and before. Your textbooks are good sources. If you go to the Federation's website, if you think you need a textbook in a certain area, just type in textbooks and it'll pull up a PDF file which has the textbooks used in PT programs and the textbooks that are used in PTA programs, and really tells you how many programs are actually using a certain textbook. Obviously, you'd want to use the one that most of the programs are using. Orthopedics, there's McGee and another author. Them looking at the book, but I can't read the author across the room. There's McGee and one other. It's by McGraw-Hill. Those are the two textbooks that are used in most programs. And one program you use one program you use the other. McGee is English originally. In the first couple editions, there were a lot of error in it, but it's cleaned up. Later editions, they just clean up. They do a lot of cleaning up between editions. Your school notes are another good source. If you notice, I did not mention anything about exam guides and things like that because they really aren't well researched and they really aren't well edited as far as content goes. They may be edited as far as format goes, but not necessarily content. Textbooks are, most publishers do a fair amount of looking through and making sure the content's halfway decent before they publish it, and then after they published it, comments coming back to them pretty much will go into the second edition, will revise a lot. Third edition revises a little bit more. But by the time you're at the fourth or fifth edition, there's really probably not much changing. Unless something new came out, then that would be mentioned as well. They would update that. Quantitative versus qualitative research. They're really answering different questions. Quantitative tells you how much. So it's really how significant something is. You can have a skewed or normal population. The results of a study here that's quantitative in nature is reproducible. If you use the same methods, you should get the same answers. And some people say the only good research is quantitative. Based on that, the fact that you can verify it. Qualitative research, on the other hand, says what things are. Not how much, but says what things are. It doesn't really say how significant things are. It describes populations. It describes diseases like a syndrome. Those type of things that are used there. So qualitative research is more that way. It depends what question the researcher is actually asking here as to what type of results they get. So it's a lot more dependent upon a more experienced researcher asking the right questions to really explore the topic well enough. Verification may be like asking a survey with the same question but worded differently, but you end up with about the same answer. That's a good way to retest yourself when you're doing surveys, is take the same issue, just word it totally different, and you should get the same response to both wordings that you've used. So you'd use two different wordings of the same thing. They should be in agreement with each other. But it takes more of an experienced researcher to really do some good qualitative research. Verification here, you cannot repeat it because you'll never see the same phenomenon exactly the same again. It's good for today, but not for tomorrow necessarily. Reliability has to do with the data. Are you accumulating the data in an accurate, reliable way? It has to do with how good the data is. If your data is crap, then you really can't say anything about validity. If your data is good, then you can. So studies need to be reliable first, and then look at the validity. Validity is it testing, or is it finding out what it should be finding out? Is it measuring what you intend, the phenomena you're trying to look at? Or is it measuring something else? Like for a test, does a test in fact measure what it is intended to test? Could be measuring something else too. Internal validity is the results actually support the internal validity conclusion. And usually if it doesn't, no jury journal will publish that. They usually let the author say what they want about external validity, which is, how can I extend this to other populations, other situations, which were not tested? So how can this be expanded? And authors sometimes run into trouble there. If you read the physical therapy, read physical therapy at all, you will see maybe after study another little article, invited commentary, and they're usually taking the author of the study to task into some of their external validity statements and saying, yeah, that probably really isn't true. And you don't really know what's true necessarily with external validity because it really wasn't tested at all. Now, you could do another study to test the external validity or one of the external validity statements. There's concurrent validity, there's predictive validity, there's prescriptive validity, which allows you to select a treatment. Predictive gives you the prognosis. Concurrent means if they have these factors, they have this diagnosis. There's also a content validity as well, which means the theory behind it makes sense. There's good logical progression there, good logical thought involved with it. Quantitative research, really the reliability is being able to repeat it. With qualitative research, you can use different methods that should achieve the same result. That sometimes helps you prove reliability or gives you a case towards it. Mobile forms, different ways of really, maybe different surveys that are asking questions slightly differently, but the major thrust of the questions are the same, but the wording is definitely different. Multiple investigators, if you have several people investigating something and they all end up coming up with the same conclusion, it's probably right. Respondent verification. When somebody responds to you back, make sure that that's what they wanted to say. So that allows you to accumulate more reliable data. A lot of the qualitative research is done by survey. Another thing about validity, maybe if it's meaningful. As I said, not all the same studies would be meaningful to you. They may be meaningful to other therapists, but not necessarily to you. Depends on your practice situation. Qualitative research, usually results of interviews, observations. They could be observation, they did this or they did not do this, and it's usually a yes or no question. The stats here are often more nominal in nature. These are higher level statistics, like ordinal types of research. Medical research is anything done in the medical field. It could be physiology, it could be anatomy, it could be pharmaceuticals, whatever. Clinical research is probably the most important because it's actually a study that was done on patients. So we actually get to see what the results are. Laboratory research is done on either tissue samples or animal models. What happens in an animal model may not happen in a human. And even a piece of tissue outside of the body isn't getting the same thing as it would necessarily inside the body. So things can work in the tissue sample or things can work in an animal model, but then when you take it into clinical research and try it with human subjects, it may not work. Outcome research analyzes the value of provided health care services. Insurance companies do a lot of this. It's something that if we go to a single payer system, it's going to be a lot easier to do because we're going to get large amounts of data to deal with, to mine, and we can go look at the outcomes of things. Patients with a certain diagnosis were given a certain treatment, what are their outcomes? And then you could even start doing multivariant as, well, they had this primary diagnosis and these secondary diagnoses, and see if you still come up with the same thing. And using large amounts of data would help us do things like that. That was actually one of the founding corners of Obamacare originally, was trying to get better outcomes. They originally wanted to have a computer system. They wanted to have one computer system that would span all facilities, so all the computer systems would easily be able to download the same type of data in the same format. Makes it really easy to research. And I'm thinking by doing that, you could actually start finding out which treatments are best, because there's very little research of comparing one treatment to another, partly because if your treatment turns out to be better than somebody else's, they end up suing you, complaining about how you did your study, because they don't want to be second best, they want to be best too. Terminology, that method of measurement or the method of conducting the study itself, really, really important, because that tells you if or if not you can actually use the information in your clinic. So you really got to look at that, and a lot of people skip that. That null hypothesis is that backwards way of thinking. You have two groups. The null hypothesis would be they're both equal and there's no difference. But one group received the treatment, one group did not receive the treatment. And if they end up being equal, it means the treatment had no effect. If they're not equal, that would be the research hypothesis, not the null. And then you accept that. If you can't prove the null hypothesis, then you have to accept that research hypothesis. The results section is where really all the stats are. And Better Done Study actually uses fairly common statistics that everybody understands. But some studies will use some fairly novel statistics, which are always a little questionable, where we don't understand what they're mathematically doing. If I don't understand that, I can't really see if the results are actually supporting their conclusions at all, either the internal validity or external validity conclusions. I've read many studies. I was on a panel at National Institute of Health reviewing wound care studies, and they all said that whatever they did to the patient improved healing. Healing is a process that has so many different variables to it. I can't see how you could prove that they heal better based on 6 patients. That's just not enough to cover all the variance there. Usually the sample sizes are fairly low, and the patients may be not very homogeneous. I saw one where they did do a little qualitative analysis of the sample population, and 40% were decubiti, 2% were venous stasis ulcers, 1% was an ischemic ulcer. You really can't mix that stuff together and still get the same type of outcome. There was a lot there, a lot of research done there, paid for by, some of it paid for by APTA, that really needed to hit the circular filing cabinet more than anything else. Research gives you the introduction, the methods, results, and conclusions. The internal validity conclusion usually is proven fairly well by the results in anything that's published in a reliable journal. External validity, maybe not. They really let the authors do whatever they want. But introduction, somewhat a little bit like your subjective evaluation. The patient gives their complaints to you, and it helps you identify where some problems may lie. Objective evaluation, you select tests and measures based on what the patient's complaining about. That's really a development of a method how to assess the patient. The results are sort of like assessment, and your plan of treatment is more like following the conclusion. Defines what you're going to address. So in clinical practice, we sort of mimic research to some extent. Not exactly, but close. As far as studies go. As far as research studies, The randomized clinical trial AB, as far as experimental research, that's probably the best. Usually the subjects are randomly assigned to a control group or the experimental group. You usually need a lot of subjects. It sort of depends how big of an effect there's going to be. If you have a huge effect, you may not need as many subjects. More subjects, the higher the cost. It's hard to follow all of them and how to test all of them as much as they need to be tested. So randomized clinical trial, probably the best way to do things. It's what the FDA used to use. They would only accept randomized clinical trials. Non-randomized clinical trial is you basically give all the patients a certain treatment. You don't have a control group at all. So it's quasi-experimental. Not as good because you don't see what a control group would do. So you may be able to see a change in these patients and measure that, but you can't compare it to somebody that did not have the treatment. Sequential trials is you do one treatment, measure, do another treatment, measure, do another treatment that measure, another treatment that measures. You also have a control group that maybe has a placebo treatment 1, 2, 3, 4, 5, but they don't receive the treatment you want them to receive. And the treatment could be maybe a higher intensity of the same thing. That could be a difference in the treatments or something, or maybe a sequential thing, where one is done after another. You have pre and post testing, which is a single subject repeated measures. So you take an initial measure on them, treat them, and take a post-test measure. You may do this for a lot of subjects as well, but each subject is treated separately. ABA, single subject, is a baseline measure A, then a post-intervention measure B, then the return to the original baseline. So you're actually using about 3 measures to see if A didn't return to the baseline but remained more like B, then you cause a chronic effect in the patient, which is maybe what you want to do, long-lasting effect in them. Longitudinal studies are done for a long period of time. Probably the most famous ones in the U.S. are the Framingham studies, which is a little community outside of Boston where they studied this one town, any medical parameter they put into it. So they just intensively studied this one population. It started back in the 40s, right post World War II, still continuing today. And the populations have changed over time. And they're seeing what has changed in that population as well. Good example of a longitudinal study. Sequential are one treatment, another treatment, another treatment in a sequence. Again, usually over a longer period of time. Outcome studies, you can do them prospectively and retrospectively. A lot of them are more retrospective, case controlled, which everybody from this diagnosis that got this treatment, this is the result they got. And you go back through patient data. Prospective is everybody with this diagnosis, that's what case control is all about, gets this treatment, and then you determine their outcome. But these are both types of outcome studies. Cohort study is relatively newer. It's now been approved by FDA to replace the randomized clinical trial. Basically what you do is you take 2 subjects that are totally matched upon any factor you think is important to what you're trying to study. So they're the same. And then out of that matched pair, one of them gets the intervention, the other one does not. And then you keep measuring them. If the research hypothesis is true, what you see is the group that's getting the intervention improves on the factors that you want. The other group does not improve. They stay the same as their baseline or near their baseline. You can get away with doing, if you use this matched pair, if you needed 1,000 subjects for a randomized clinical trial, you might be able to get away with 10 subjects doing a cohort study, as long as they're well matched. Problem is, are they well matched or not? Do they cover all the factors that would be important in determining the outcome within the match itself. And that's sometimes a little questionable. They might not do that. This thing I've seen in several textbooks, fairly exact. So all textbooks pretty much what I've talked about so far, pretty similar. So a question written about some of this stuff might be able to get through a pre-testing. There will be a fair amount of tests and looking for error problems, because that's how we decide whether or not it's more specific or more sensitive type study. So the sensitivity and specificity comes out of this, and it's all based on error. It's when it makes a mistake. The gold standard is what gives you the best answer. It's the most reliable. If I want to know if your ACL is torn, I can cut your knee open and look at your ACL. That's probably the most reliable thing. But I don't think you really want your knee cut open with arthrotomy to be able to see if your ACL is intact or not, because the recovery time from that is going to be fairly lengthy. You probably don't even want a scope stuck in there. Now, a scope has its limitations that it can see the front of the knee, but it can't really go into the posterior horn type area. It might miss some like a PCL being torn. There's certain errors to different tests. MRI, it depends where the slice is, and sometimes the ACL can look like it's intact. Sometimes it can look like it's torn when it's actually intact. There's error both positively and negatively. The specificity of the test, when we start testing somebody, we usually start off with sensitive tests first, so let's go there. It identifies, I use it to identify subjects that should be positive. If somebody is positive, they'll probably show up as being positive on a sensitive test. But they also could be, there could be something else making them positive as well. So there are some false positives as well with this. It's also called a type 1 error, or an error of the first kind, but we're looking for those false positives there. And sensitive tests have a lot of false positives to them. Like if you use Apley's distraction for the ACL, yank on their leg, they go ouch. That's a positive test, but it could be the medial collateral, it could be the lateral collateral, it could be the PCL, it could be the tendons of the gastroc or the hamstrings across the knee, it could be the sartorius that wraps around the knee. If those tendons are really inflamed, they'll probably have a positive Apley's distraction as well. There's other things that could throw that error in there. But if I want to see if a patient maybe has a problem, a sensitive test is probably the way where to start. Once I get a positive sensitive test, then I may want to go to more specific tests. It tells me, well, specific tests have fewer false negatives to them. They don't have false positives, but they will have some false negatives. EMG is a good example of that, because when you stick a needle in somebody, you'll see certain things, but are you sure which muscle that needle's really recording from, or which portion of muscle that needle's recording from? You just may not have the needle in the right spot. So there's a lot of times when you do an EMG study and it comes up relatively negative on a patient, it doesn't really exclude they have it. It just means you didn't find it. Like an acute fracture, the radiologist always says no fracture seen. They will not say there's no fracture there, because a stress fracture, a hairline, you won't see an acute x-ray. About 10 to 14 days later, you start seeing the callus of the bone, then you can see if it's fractured or not. There probably are more questions over this than anything else, and this really has to do with your measurement error. But this is called a type 2 error in some textbooks, error the second time in some other textbooks, an alpha error, which makes it really hard to figure out what the author's saying. Specificity and sensitivity, probably the most likely way you'll see it on the exam, because it's what we use as physical therapists a lot. But the statistician is going to come more off of the error, so a type 2 or type 1, or error of the second kind, which is the type 2, an alpha error. And it's all based on false negatives here, where the sensitivity of the test is based on false positives, where the test reads positive, but they don't have it. False negatives, they do have it, but the test said they didn't. So it's all based on error. There are about three major types of statistics used. You could break it up into two groups, being parametric and non-parametric. Non-parametric is primarily used for qualitative studies. Parametric is used more for quantitative studies. Instead of two types, there's actually two. It should be two, not three. One of the prime differences is the power. There's more power with parametric statistics, but parametric statistics are based on a normal curve, a normal distribution. So that's an assumption that needs to be made. Sometimes your sample, particularly when you're doing small sample sizes, may not be a normal representation of the population that you're trying to study, particularly in low sample numbers. Your sample size just doesn't have many people in it. Non-parametric can rank data sometimes. The Spearman-Rowe data is for rank order data, where one data point is more than something else, another point, but it's not an even amount more than another one would be. Grades, A, B, C, D, D, E, or A, B, C, D, F. That's sort of a rank order, because an A can be anywhere from 90 to 100, and 100 is definitely different than a 90. So it doesn't take into account the small differences. You may have a lot of people at 91 and maybe one at 100. It's still going to be how many people fell within that 90 to 100 block. So it's not very great. You'd not want them to determine class rank based on that, because you'd have a whole bunch of people ranking the same way. It wouldn't separate things out very well. Not all distributions are normal, and that's when you start, if it's not a normal distribution, you've got to use non-parametric. Type of data, nominal. It's just a qualitative measure. They either have a factor or they don't have a factor, and you name it. And you can count how many are in that group. Chi-square is used to basically analyze that data. And you can have multiple factors in a chi-square. You can look at 3 independent and 3 dependent variables or something like that. So you can have multiple factors in there, but you just really either have it or they don't have it for each subject. Ordinal is that rank order. Interval is when we see the quantitative statistics come into play, because there has to be equal units of measure. There has to be equal distance between the measuring points in there to say if something's truly greater or smaller. And quantitative, we're talking about how much. See a fair amount of that. We don't see much ratio because it assumes there's an absolute zero, absolute absence of a factor. Rarely is that the case in something we deal with. Nominal and ordinal data is considered to be non-parametric, used more in qualitative studies, where interval and ratio is parametric data, which can be used in quantitative studies, although ratio we don't see a whole lot of, because it really doesn't apply to the human body very well. It's rare that you'd have a total absence of something. You may not have a significant amount, but I doubt you see a total absence of a factor. Distributions, we have a normal distribution, which has that bell curve to it. Parametric data follows this. How many patients fell within 1 standard deviation? Well, with 1 standard deviation fell within 1 standard deviation of the mean. You got half of them here, got half of them here, because half of them fell above it, 1 standard deviation above, and half went to 1 standard deviation below the mean. So it'd be 68%. You got to add it together. What percentage of the population fell 1 standard deviation above the mean? It'd just be 34. So you need to read these questions relatively carefully to get this. It's usually a 1 standard deviation thing they give you. There is 2, there is 3. You can cut it as many ways as you want. They tend to get a lot smaller very quickly. Like by 3, let's see, 1, 2, 3, 4 would be 0.13% of the population, which is fairly infinitesimal amount. Even 2.14 is a pretty small amount. They could hit you with 2 standard deviations, which I think has been on the exam. But again, within, below, or above the mean, they're going to use those terminology and ask you for that. They're asking you for a number as an answer choice. whenever we're describing a population, there are three factors. There's the three M's. The mean, which is the average. That may or may not tell us something. Like the mean of neurological disease in the Chicago area doesn't tell us anything. The median is the midpoint. That rarely tells us anything. But the median is sometimes used to calculate how reliable your data is. The mode is the most frequently addressed score. So neurological diseases in the Chicagoland area, the mode is probably the most important there, because I'd like to know how many MS cases are, how many Guillain-Barré cases are. So I would expect to see MS probably being the highest of the bunch because it's more common. But we'd find that via the mode. So they may ask you which is one of the most important ones to look at. And when they do an answer choices like this, probably one would be the mean, one would be the median, one would be the mode, and they need a fourth one, so it may be off totally in left field. You may say standard deviation or something like that. Oftentimes when you're writing questions, you'll come up with three really good answer choices and you can't come up with a fourth. So, but you got to put something down. So it may be totally not related at all. And that also defeats one scheme for taking multiple choice exams, which is not even to read the question. All you do is look at the answer choices and find out which one doesn't go with the other ones. If the last one was standard, the first was mean, median, and mode, and then standard deviation. Well, standard deviation really doesn't go with mean, median, and mode, so that may be the right answer if you're just doing it that way. They don't want to see little tricks like that allowing people to pass the exam, because it's really not a very valid exam if that happens. They want to see you know your stuff. Populations can be skewed. When they're skewed, they're not normal anymore. Positive skew, the mean is over here, mode may be somewhere in this area, coming down. So I actually have a fairly large percentage of the population here, not that much of the population over here. Negative skew, it's the other way around. And that's where the mean is, or where the mode is in relationship to the mean. Like the mode's going to be over here, but the mean probably be somewhere right around there. And the median's going to be in the middle of the range. Middle of the range doesn't tell me much. In a true normal population, the mean, median, and mode should be the same. And how different it is, how much the mean differs from the median, determines how close to a normal curve you have, or a normal population that you have. Kurtosis has to do with this being very peaked, being very flat, or being what would be a true bell curve. Here, I actually have three different populations. Each peak is going to be a different population. If I have three different populations, that mean doesn't mean diddly squat. Doesn't tell me anything. But graphing it out would give me a hint that I have definitely three different populations. There's something different in this group from this group, and there's something different in this group. I got to figure out what those are, or I should do studies to try to figure that out. Independent versus dependent variable. Independent is what can be changed or set. Dependent variable is a result of that. It's a measurement you make as to what the result was. So I can set electrical stimulator on a certain frequency, and then I'll set it on a different frequency, and then set it on a different frequency. I'm changing that frequency, I'm setting it. Then I'm looking at maybe how many motor units I have recruited. That would be the dependent variable. Here, with relationships, Pearson R is probably the most common statistic that we use to do it, but there's a whole bunch of different stats that can also look at relationships slightly different ways. But that green line and the red line are straight. So if I know where something is down here, I can come up to that red line and know exactly where it'll be on this axis. This blue thing is sort of all over the place. There's a central direction to it, but there's no, if I'm here, I'm within a range over here, and maybe a fairly large range. So I don't know exactly what it is. Linear regression is related to this. The Pearson R, or the Pearson correlation coefficient. There's a Spearman-Rowe for using rank order data that looks at relationships as well. Linear regression is probably used more for quantitative type data, but you can predict what would be, the idea is predict what would be next with linear regression, but the idea is to figure out where that line really is and extend it. The Pearson R correlations between 0.76 and 1 shows a good to excellent relationship. 1 is a perfect relationship, but 0.76, 0.75 is good. 0.5 to 0.75, that's a moderate to good relationship. 0.26 to 0.5, really only a fair. And 0.01 to 0.25 is a very weak relationship. Maybe the reason the relationship exists is pure error at that point. So I would probably go ahead and believe the study and start utilizing the results of that study to change how I'm doing things. If I have a strong relationship, 0.76 to 1, definitely. 0.5 to 0.75, maybe. Starting getting to fair, probably not, and weak, definitely not. Spearman-Rowe's used for rank. Kendall's tau is used for small data groupings. You're still using a lot of fairly small data subsets here, so if one subject is fairly different, it could really skew it a lot. And chi-square is used for that nominal data that we see a lot in qualitative research. Spearman-Rowe rank order is actually qualitative as well. Agreement means things should be the same, and that's inter-test reliability, intra-test reliability, and parallel reliability. Inter-tester, between two different people conducting the same test on the same subjects. They should get the same results. They won't, to some extent, but they'll get similar. Intra-tester is the same individual testing multiple subjects. They should always, and you could be repeating the test, and each time they repeat it, they should get the same answer back, unless something has changed. Parallel reliability is two different methods of getting the same result. Like with muscle, you could have isotonic testing, how many pounds they lift, and compare that to peak torque from isokinetic testing. They both are talking about muscle strength, but they're both very different values. The isotonic is really the weakest part of the range of motion, stops you from moving. So that's where your number comes from. It comes from the weakest portion, the portion of the range of motion with least mechanical advantage that would cause that patient only to lift that much as a max lift. Isokinetic, on the other hand, the peak torque comes from the portion of the range of motion that probably has the most mechanical advantage, not the weakest portion. So they're very different numbers, and how you could use them could be quite a bit different. I can make more out of the isotonic number because I can give them lifting precautions or lifting restrictions based on maybe 70% of their maximal effort, things like that. I can't do that with peak torque. Now, peak torque will increase as the patients get stronger, as long as you're at the same degrees per second. So it is a measure of strength too. Manual muscle testing is another measure of strength that's classically used. But it's different ways to assess the same thing. And that's really what parallel reliability is all about. It's different ways to assess the same thing, and they should get the same results. Interclass correlation coefficient is used to assess this a lot. Basically what you do is you take the average of all the different points, average it together, add it together, divide it by the number of subjects you get. That gives you sort of the result of this. It's not the mean, but it's sort of like that. And the ICC should fall between 1 and -1. The closer it is to 1 or -1, the stronger the agreement is, or the absolute value of 1. They could throw something like that on an exam too. Confidence levels, here's where the mean and the mode and the median are looked at. How different are they? If they're really different, I'm probably going to have less of a confidence. If they're almost identical, I could have 100% confidence, for instance. Rarely do you have that. But I could have a 99 or 95. Usually 99 and 95 are both accepted clinically as something would indicate that you should do. ANOVAs are used for quantitative analysis. A t-test is simply a type of ANOVA. Chi-square is used for non-parametric nominal data. And there's something called the strength of evidence ratings. This is something that I used a lot at NIH, going through research studies and trying to summate the results of many research studies. A is the strongest as a result of 2 or more randomized clinical trials. They're coming out with the same result. They'd be randomized clinical trials by 2 different researchers, very independent of each other. So if you have 2 very independent entities coming up with the same result, it's probably true. That's your strongest. B would be the results of 2 or more controlled trials, which aren't as accurate. They're not as strong. It could be animal models in there, things like that as well. And C is probably the least, has the least strength to it, like an expert opinion. Well, that's their opinion. May it be true or not true? We don't know. PT was always based on expert opinion for a long time before we got into the evidence base. But that was really what we used a long time ago, was like McKenzie said and things like that. Well, McKenzie wasn't always right. Bobath wasn't always right. But they said it, so you had to do it. Now we're getting into more experimental evidence instead. So it's supplanting that. Case studies are talking about what happened to one patient. Now, if you read case studies, it's not so much the outcome you want to come away with or the conclusions. It's the method they did to get to the conclusion, the method they used to assess the situation, if you read a lot of case studies. And it's more the methodology there that could pick up, because you're going to use that methodology many different ways to be able to solve different problems. But that methodology is fairly important. And the result of one case-controlled study. Again, it's not repeated. A case control does not have a reference group at all with it, so you can't compare it to that. It's not like a randomized clinical trial. So one, yeah, it says a little bit, it may be happening. You see B and C used a lot for pilot studies and things like that, where they're just trying to investigate maybe what's going on. And if the pilot turns to be positive, and you may do a pilot to give you evidence enough to get human subjects assigned to you to do a randomized clinical trial, you may want to see it happen in an animal model before you try it on human subjects. The animal models would be in the B category. The cohort studies are probably somewhere between A and B. They're not as strong as A, because it depends how you selected that cohort. And if you didn't select the right factors or omitted a factor, that could make a big difference in the outcome. You need fairly good experience to be able to look for all the factors that are necessary as well. And more experienced researchers might be able to do that. You're getting data that looks very much like a randomized clinical trial. You're presenting it the same way. You are getting a little p, which says, well, if p equals 1, that means it's totally due to error. P with a bunch of zeros, maybe a 1 or whatever integer you want to throw in there. The more zeros, the less due to error it is, and the more actual the thing is. So that's what you're sort of looking for, is your result is not due to error. And the P, the smaller it is, be it positive or negative, the less error there is around. The cohorts are going to fit somewhere right between A and B. I'd put it's either a B plus or an A minus. Did that give you a fair amount?
Yes.
Yes.
Did it make some sense out of this stuff?
Yes.
Because this is one course that I know of in school. It's rare to find somebody really getting into it. We didn't go to PT school to be researchers. Also, too, the exam's going to focus on more you being able to read research, be a consumer of research, to be able to adapt and constantly be modifying how you're working with the patient in the clinic. You must always be striving to do more and do better. And that's the reason why we need to read the research. Things do change. and you need to catch up on it. Neuro is changing phenomenally right now. I would say most of the neuro textbooks are probably fairly out of date. It takes about 5 to 7 years to do a textbook and get it through the editing phase to the point of being published. So they're really lagging behind the evidence quite a bit anyway. And then neuro, a lot of the authors are NDT people, and they will not get off the NDT no matter what. They're not, and NDT does not agree with a lot of evidence that's out there that's been accumulated since the early 80s, and more has been accumulated since. NDT was a good example of a theory from Bobat, basically a takeoff on Bobath, that was around when we really didn't understand how the brain worked. We didn't really understand the physiology behind things. We knew a little bit of the anatomy, but we know a heck of a lot more now. We didn't know about plasticity at all in the central nervous system. NDT was a theory you treated people by. There were several different neurotheories going around at that point. NDT is the only one that somewhat has lasted. It's lasted because it was really fairly rigid initially and considered to be the best neurological treatment for many years. But it's definitely has its problems because not everybody develops the same way. And development may not have a heck of a lot to do with stroke. It really doesn't apply there. But even in working with pediatric patients, not every kid develops exactly the same way and in the same order. We know they need to develop certain things by certain times, but we're not exactly sure what those times are. It may be a little bit wider. We don't know where that window is. That really hasn't been very well defined at all. I know some studies have attempted to do that. There's a lot of pediatric studies out there, but unfortunately the pediatric studies are looking at 4 kids with CP. The sample sizes are really too small to say much of anything. You might be better off just doing case studies. And you can do a literature assay of case studies and everybody with the same diagnosis and sort of translating the evidence or the outcomes into the same format. You may be able to compare them or add them together and get a pretty good idea what's going on. Okay, I think tomorrow night will be prosthetics on the list. And prosthetics and orthotics, they're going to look at it very biomechanically on the exam, but that's where we're going. So if you want to, 8 o'clock Central Time tomorrow night, I'd be glad to see you. Any other questions?
No.
Okay. See you tomorrow night?
Have a good night, Tim.
Okay. Good night.